Hello guys, this is Dr. Parth Fanse. We are going to talk about psychiatric today. And in psychiatric, we are going to discuss about mood disorders or it is as affective disorders. Now, before that, let's talk about classification of mood disorder. So first of all, what do you mean by mood disorders? Mood disorder is nothing but we can call it as abnormalities or abnormality of our mood is called to be mood disorder. Okay, so mood disorders. Now we'll talk about classification. Mood disorder is being classified into two groups. The first one it is called to be depressive disorders. Depressive disorders, and second one we called it as bipolar disorders. Depressive disorders and bipolar disorders. So, we'll talk about depressive disorders and bipolar disorders in a graphical representation. And we very well know in depressive disorders, a person may always feels sad. So, between two attacks of sadness, a person will be happy. So, let's talk. Person will not be, but person will be normal. So, if we talk about the graphical representation, consider this to be on a happier side and this is a sad part of depressive disorder. So when a person is feeling sad, when there is two attack, the time period between two attack of sadness, person will be normal. I'm not saying happy, I am saying it will be a normal person will be normal. If I am say talking about if I'm talking about bipolar disorder, if I'm talking about bipolar disorder, and if I'm making a graphical representation, let's take a similar aspect. Let this be a happy side and let this be a sad part. So it is bipolar disorder. Person will be happy as well as sad, but between the attack of happiness and sadness, the period will come in what a patient will be normal. So let's draw in a graphical representation. Consider this to be a attack of sadness. Consider this to be a attack of happiness. Consider this to be a attack of sadness again, and consider this to be an attack of happiness. Between this time, this time, a patient will be normal. A patient will be normal. This is called to be bipolar disorders. Okay. So we are going to talk about first. We are going to talk about depressive disorders, and in depressive disorder, the first one we are going to talk about major depressive disorder. We are going to talk about major depressive disorder. It is also called to be unipolar depression, or we can simply call it as depression. So only major depressive episodes can be seen in major depressive disorders. First, we want to talk about epidemiology. Epidemiology means in what age criteria we can see, in what gender more commonly depressive symptoms are seen. So if we talk about epidemiology, major depressive disorders are more commonly seen in females than males. Mean age and average age of onset of depression is around 40 years, and this 40 years can be named it as middle age females. So in middle age females, depression is more commonly seen, and what is the age? It is 40 years. So mean age of onset of depression is 40 years. That is middle age female. Now we can talk about etiology. There are various reasons behind the depression disorders. There are four reasons, four etiology behind it. The first one is neurotransmitter. There are various neurotransmitter which plays role in happiness and sadness of our life. If we talk about depression, there are three main neurotransmitters which play a major role in causing depression. The first one is 5-HT. It is nothing but it is serotonin. Then it is ND, that is norepinephrine, and DA is nothing but it is dopamine. But the most commonest thing what we want to remember is all these neurotransmitter will be decreased. All these neurotransmitter will be decreased. Then there is also reason for hormonal reason. What hormone is responsible for depression? It is hypothyroidism. Which hormone is responsible for depression, it is thyroid, and in thyroid, what condition? It is hypothyroidism. It is hypothyroidism. Yes, as well as there are genetic factors which are responsible, and genetic factors may be a reason for a depression, may be positive. Okay. Then there is cognitive theory. In cognitive theory was given by a scientist whose name is Aaron Beck. Who was a scientist who gave who gave cognitive theory? There was a scientist whose name is Aaron Beck, and this Aaron Beck explained about negative automatic thoughts. Aaron Beck stated in cognitive theory about negative automatic thoughts. He talked about negative automatic thoughts. Okay. So what does he postulated in a cognitive triad of depression? He postulated a cognitive triad of depression. There were three things what is stated about. A person always feel negative view about self, that is called to be worthlessness. Means a patient will not feel its worth in its life. Then what about environment he stated? He stated a person feels helplessness. A person feels helplessness. And what about he talked about future? He will be hopeless. But we always say to student, never lose hope. But if a person is suffering from depression, he will always feel hopeless about his future. Now the question arises, how can we diagnose is a patient suffering from depression or not? So for diagnosis, we have a mnemonic what we need to remember, and that is called to be Psych-CAPS. I'm writing over here Psych-CAPS. Psych-CAPS. Okay, we want to remember a mnemonic that is Psych-CAPS, by which we can diagnose a patient is suffering from depression or not. Okay, let's classify what do you mean by Psych-CAPS. I'm writing over here. Pay attention to the screen. Okay, so what is S? Means S is for sad or depressive mood. S is sad or depressive. Sorry, I have mentioned it is disorder, but it is mood. Okay, so what is I? I is increase interest. Increase interest, and that feeling when a person is having less interest in a surrounding, it is called to be anhedonia. Anhedonia means a person is not having interest in surrounding. What is G over here? G is nothing but a person is feeling guilt, or we can call it as worthlessness. What is E? E means energy decreased, or person is having fatigue. Easy. A person can get easily fatigued. What is C? Decrease in concentration. Decrease in concentration means it is called to be pseudo dementia. I will talk about dementia in a later half, but just remember C is for decrease in concentration for depressive patients. What is A over here? A is nothing but it is appetite. See, appetite is an debatable thing. In some patient there can be increase, and in some patient there can be decrease in appetite. What is P over here? P over here is nothing but it is PMA, that is psychomotor activity. Why I have mentioned it with black color? Because it is same as appetite. In some patient it increases, and in some patient it decreases. Okay, moving to the S. What is S over here? S is nothing but it is sleep. A person will feel insomnia. Insomnia means patient को नींद आएगी नहीं. Then what is next? S is for suicidal thought. A person will be having what? Person will be having suicidal thought in depression. Am I done with this thing? Moving to the next part, that is major depressive disorder, that is recurrent one. Now, again and again, when the attack recurs, we call it as recurrent depressive disorders. When we can call it as recurrent, when there are two or more episodes of depression. When there are two or more episodes of depression, it is called to be what? Recurrent depressive disorders. Okay. How can you specify that a person is suffering from major depressive disorder that is recurrent? So we can mention it by the first one, that is with psychotic symptoms. A person will be suffering from psychotic symptoms. What sort of psychotic symptoms you can see? A person can have depression, can have hallucination, and can have delirium. A person can have depression, hallucination, and delirium. These are the psychotic symptoms what we can see in a recurrent depressive disorders. Okay. And if you want to look for on a graphical representation, let's draw a graph by which a graphical representation we want to study is like this. See, means a person will be having recurrent episodes, means increase gone. This is nothing but it is recurrent. It is recurrent. It is recurrent. Okay. It will be like, how can you treat the patient? You can treat the patient with antidepressants. You can treat the patients with antidepressants, and along with that, you can use antipsychotics as patient is having psychotic symptoms. As patient is having psychotic symptoms. So I am mentioning like sorry, I'm writing here as plus antidepressants plus antipsychotics. Okay. Next, there is one more symptoms what we can see in the patient of major depressive disorders is nothing but it is that we can see a catatonic sign. Now, you may have a question, what do you mean by catatonic signs? So, catatonic symptoms are something different which we will discuss in a later half. For now, just remember, patient, we have to treat the patient with IV lorazepam. And you very well know lorazepam belongs to what group? Lorazepam belongs to what group? It belongs to benzodiazepines. Okay. You may have a question about catatonic. We'll discuss in a later half. But what do you mean by catatonic signs? Okay. One more treatment along with this catatonic treatment, you can give ECT plus antidepressant. So there are two ways. What is ECT? It is electroconvulsive therapy, and along with that, you can give antidepressants. You can give what? Antidepressants. Okay, let's talk about another specifiers. The most commonest question which comes across, and this is a combination of psychiatric plus OBGY, and you can expect one MCQ from this 100 percentage. What do you mean by postpartum blue? What do you mean by postpartum depression? What do you mean by postpartum psychosis? So postpartum blue is very common. It is, we can see in 30 to 75 percentage after delivery in women. And what is postpartum depression? We can see in 10 to 15 percentage of the females. And postpartum psychosis, it is very rare. We can see either one or two cases in the ward after 1,000 child births. How can you differentiate either it is postpartum blues, depression, or psychosis? So if you want to differentiate it is blues, depression, or psychosis, it begins on the onset. Postpartum blues, it starts between 3 to 5 days and it lasts up to weeks. But what are the symptoms of the patient? It is almost same. It is transient mood disturbance, sadness, and tearfulness. What is postpartum depression? The onset of postpartum depression, it is within 6 weeks. It can see after delivery, patient can suffer from suicidal thoughts, patient can feel guilt, and it can suffer from anhedonia. What is anhedonia? It is loss of interest. We have already talked. Loss of interest. Okay. What is psychosis? Psychosis is nothing but patient can have irritability, sleep issues, anger, delusions can be there, hallucination there, and a person can feel, a lady can have a thought to harm a child, I mean infant or self, can have a baby this become dead, or the baby is not mine. These are the symptoms what a patient can have of postpartum psychosis. How can you treat these diseases? If a person is suffering from postpartum blues, nothing you need to do, nothing, just supportive care is more than enough. But if a patient is suffering from post depression, you have to give SSRI, CBD, but there is a new drug in the market whose name is Brexanolone, which is mainly marketed for postpartum depression. Then you have to treat antipsychotic, a lady suffering from psychosis, because we can see psychotic symptoms, yes or no. So that's what postpartum blues, depression, and psychosis. Let's talk about the treatment of depression. So, for the treatment of depression, we are going to talk about antidepressants. So, antidepressants are further differentiated into three groups. The first one is SSRI, second one is SNRI, and third one is NDRI. So in the table I have mentioned some drugs. For if it is SSRI, sertraline, fluoxetine, paroxetine, citalopram, escitalopram, and vilazodone. If I talk about SNRI, it is venlafaxine, desvenlafaxine, duloxetine, milanesipran, and levomilisipran. Okay, we'll talk about NDRI. I'm mentioning some drugs which is most important in terms in pharmac also and as well in psych also. So before that, talking with the SSRI. SSRI is most important because it is mentioned it as drug of choice. So drug of choice for the depression is nothing but it is SSRI. So now if it is drug of choice, you need to remember about side effects. And there is one contraindication of one of a drug which you cannot give in pregnancy. So coming to that one. So always remember a drug which is contraindicated in pregnancy. So consider mnemonic P for P. P for pregnancy and P for paroxetine. So which drug is contraindicated? Which drug is contraindicated? So paroxetine is contraindicated in pregnancy. Paroxetine is contraindicated in pregnancy. So let's talk about side effects of the drug. What are the side effects? The most common, you very well know, when someone asks about side effects, we all answer nausea and vomiting. Yes, nausea, vomiting is very common. And along with that, we can write it as diarrhea. But apart from this, a person can suffer from constipation, vivid dreams, dry mouth. But what we need to remember is about most common long-term side effect. And long-term side effect is nothing which is very useful. We can take it in either way. We can use, we do have a long-term side effect, that is sexual dysfunction. Why we use these drugs? For one of a reason, we'll talk in a later half. But most common side effect is sexual dysfunction. What type of sexual dysfunction you can see? That is decreased libido. And most important is delayed ejaculation. Means if a person is suffering from premature ejaculation, you can use what? You can use SSRI. मतलब हम यूज करें उसका साइड इफेक्ट यूज करें. मेरा पर्सन इज सफरिंग फ्रॉम डिलेड इजेक्यूलेशन, तो हम उसको दे रहे हैं SSRI. Okay, am I done with this thing? Okay, let's come to SNRI, that is venlafaxine, desvenlafaxine, duloxetine, milnacipran and levomilisipran. उसमें एक ही चीज याद रखना है, वेलनाफ्लेक्सिन एंड डेसवेलनाफ्लेक्सिन का साइड इफेक्ट क्या है? इट इज हाइपरटेंशन. इट इज नथिंग बट इट इज हाइपरटेंशन. ओके, नाउ कमिंग टू एनडीआरआई. एनडीआरआई में एक ड्रग याद रखना है अभी, दैट इज मोस्ट इंपॉर्टेंट, दैट इज बुप्रोपियोन. इट इज बुप्रोपियोन. उसका साइड इफेक्ट सबसे कम होता है, दैट्स व्हाई वी कॉल्ड इट इज लीस्ट साइड इफेक्ट. इट हैज लीस्ट साइड इफेक्ट. But one side effect which is commonly seen in this patient is nothing but it is seizures. Side effect which is more commonly seen is seizure, but it is very rare even. It is least side effect. Okay? Okay. Coming to next part, that is fourth way how can you treat the patients. We have talked about three drugs: SSRI, SNRI, NDRI. Yes or no? Coming to the fourth one, SARI. 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 Okay, that is serotonin antagonist and reuptake inhibitor. उसमें एक ड्रग याद रखना है, that is trazodone. That is trazodone. Okay, what is trazodone? It is belongs to SARI. And one more drug what we need to remember in SARI, it is नेफाजोडोन. अब नेफाजोडोन मैंने इसीलिए मेंशन किया, उसका साइड इफेक्ट अपने को याद रखना है, बिकॉज इट इज हेपेटोटॉक्सिक ड्रग. इट इज हेपेटोटॉक्सिक ड्रग. डन विद दिस थिंग. पक्का. फिफ्थ ग्रुप अपने को याद रखना है, माओ इनिबिटर्स. अब माओ इनिबिटर्स क्या होता है, यू वेरी वेल नो चीज रिएक्शन, यू स्टडीड इन फार्मेकोलॉजी. whenever you take when a person is on a mao inhibitors and he is having a red wine like which is more especially rich in tyramine, a person can suffer from cheese reaction. तो ये चीज एक फार्मेक से याद करना है. Can show a side effect of cheese reaction if a person is on mao inhibitors and if a person takes things which are rich in tyramine, example red wine. You will study in pharmac itself, but still I'm writing over here. Mao inhibitors gives side effect, that is cheese reaction, if a person is having on Mao inhibitors and taking some things like which is more common, more rich in tyramine. For example, red wine. Okay, fine enough. So last, not the least. ओके यहाँ पे दिया हुआ था, आपने देखा नहीं, हमने माओ इनिबिटर सारी दिया हुआ है. इट्स ओके. लेट्स कम टू टीसीए, tricyclic antidepressants, and it is, yes, it is toxic, have toxicity like CNS, CVS, ANS. CVS CNS का साइड इफेक्ट होता है सीजर्स और कोमा. CVS के होता है एरिथमिया और इंक्रीज QRS ऑफ ECG. ANS is side effect is dry mouth. It is dry mouth. Done. एक चीज लास्ट बट नॉट द लीस्ट, द लेटेस्ट ड्रग which is invented for this particular depression, it is gapiron. It is gapiron. It is gapiron. Okay, I'm mentioning it again. Gapiron. Mechanism of action, it is selective. Sorry. It is selective agonist at 5-HT1, that is serotonin receptor, और सिलेक्टिव हम बोल सकते हैं उसको partial agonist. We could call it as partial agonist. Then another way of treating the patient with psychotherapy, which is the best psychotherapy, it is CBT. What is CBT? अभी हमने बात लास्ट में देखा था CBT. हाँ है ना. CBT क्या होता है? It is cognitive behavioral therapy. It is cognitive behavioral therapy. Okay, fine enough. But treatment of choice, there can be question, okay, how can you treat the patient? What is the treatment of choice? So treatment of choice is nothing but it is SSRI plus CBT. Why it is SSRI? क्योंकि हमने बोला drug of choice for depression is SSRI. So how can you treat the patient? What is the treatment of choice? It is SSRI plus CBT, that is cognitive behavioral therapy. एक से बोले दो. Fine enough. So other, if a patient is having pregnancy plus depression and plus she is having suicidal thoughts, Then you can give what? You can give ECT. What is ECT? Electroconvulsive therapy. Electroconvulsive therapy. And this nowadays it has been modified with anesthesia and muscle relaxants. Muscle relaxants. So we have completed here the first part, that is depressive disorder. Coming to next, it is bipolar disorder. Coming to our next topic, that is bipolar disorder. When a person is suffering from depression and mania, when a person is suffering from depression and mania, it is called to be bipolar disorder 1. Bipolar disorder first. How can you differentiate? We are going to talk about. Let it be. Second, if a person is suffering from depression and hypomania, it is called to be bipolar disorder 2. We are going to talk about bipolar disorder 2. Okay, and mania, you very well know what is mania. Still, we'll talk about in a graphical representation. In a graphical representation, when we draw as a graphical representation, see, this is a graphical representation. अब इसमें क्या होगा? Person will be having depression and a happy excitement. Depression, excitement, happiness. Depression, excitement. This is bipolar disorder, happy, sadness as well, both sides. Okay, so consider this to be a depressive part. This is, let it be the depressive part. Okay, it is depressive part. अब ये हो जाएगा recurrent depressive disorder, because it is recurrent in after a certain time, it will be recurrent disorder. Okay, it will be recurrent disorder. Okay, now this will be what? This will be hypomania, means a small part of happiness in the particular time, it is called to be hypomania. Again, a person is having to feel sad, it is depression. Similarly, cycle continues. Okay, fine enough. Okay, now what are the symptoms of mania? हम मैंने बोला ना अभी mania की बात करेंगे. So what is mania? So let's talk about epidemiology. Epidemiology, mean age of onset of mania is 30 years. Is 30 years. डिप्रेशन में क्या बोला था? 40 years. मिड एज फीमेल 40. बट अगर हेमेनिया की बात करें तो मीन एज क्या है? 30 years. Done. And yes, similar depressions in females, it is more commonly seen compared to males. Compared to males. Am I done with this thing? Should I move to the next point? Okay. Let's start with symptoms of mania. Now, symptoms of mania, अगर mood की बात करें, so if I talk about mood, mood will be irritable. Mood will be irritable. Energy, अब ये डिप्रेशन से उल्टा जाएगा. अगर ये एनर्जी की बात करें, डिप्रेशन में पेशेंट वाज इजीली गेटिंग फैटिग. एनर्जी इसमें क्या होगी? बढ़ जाएगी. मीनिंग इज हाइपर एक्साइटेबल स्टेट. यस और नो? एंड यस, पेशेंट विल बी डिस्ट्रैक्टेबल easily. It is distractibility, impulsive. And like for example, person can be overspending. पैसा ना होने के बावजूद भी वो खर्चा करने वाला है. It will be overspending. Okay, एंड ओवर रिलीजियस. इतना सारा खुदा पे प्यार आता है. ऐसे हम नहीं करते एग्जाम, 150 दिला दो ऊपर वाले, 150 दिला दे, है ना? सिमिलरली सेम मैनर, ओवर स्पेंडिंग, ओवर रिलीजियस, ओवर फैमिलियर. जो कभी भी फैमिली में ध्यान नहीं देता है, वो बहुत सारा फैमिली को प्यार करने लगता है अचानक से. दैट इज ओवर फैमिलियर. एंड इंक्रीज सेक्सुअल एक्टिविटी. अब ये चीज सोच के तो सबको ऐसा लगेगा हमें भी मेनिया है, पर जरूरी नहीं है. होते हैं किसी किसी की लाइफ में एक दो फ्रेंड्स जो हाइपर सेक्सुअल होते हैं. है हमारे लाइफ में भी एक दो दोस्त जो हाइपर सेक्सुअल है. विल टॉक दिस ऑन अ लेटर हाफ. फाइन इनफ. देन अ पर्सन कैन फील अबाउट ग्रैंडियोसिटी. ग्रैंडियोसिटी, व्हाट इज ग्रैंडियोसिटी? इज नथिंग बट अ पर्सन फील्स कि मैं मोदी को सिखाता हूं देश कैसे चलाना है. दैट इज ग्रैंडियोसिटी. है ना? होता है, कोई बड़ी बड़ी फेंकता है, मैं ये हूं, मैं वो हूं. दैट इज ग्रैंडियोसिटी. एक्टिविटी बढ़ जाएगी, है ना, पर्सन एक्टिविटी विल इंक्रीज। स्लीप क्या होगी, उसको नींद कम आएगी बिकॉज इट इज हाइपर एक्टिव। नींद कब आती है, जब हम थके हुए होते हैं, ये पर्सन कभी थकता ही नहीं है ना, और बहुत सारी बातें करने लगता है। सो वी विल टॉक अबाउट इट, विल टेल इन अ मैनर लाइक इट इज टॉकेटिव, इट विल मोस्ट टॉकेटिव। ओके, देयर आर सम पीपल इन, सभी के फ्रेंड सर्कल में होते हैं जो ज्यादा बात करते हैं, सो मे बी दे आर सफरिंग फ्रॉम मेनिया काइंड ऑफ। ओके, जोक्स अपार्ट, कमिंग टू हाइपोमेनिया। व्हाट इज हाइपोमेनिया? हाइपोमेनिया बेसिकली हम बोलते हैं 4 डेज तक उसका पीरियड रहता है, अफेक्ट उसका 4 डेज तक रहता है। बट मोस्ट इंपॉर्टेंट, ओके, मोस्ट इंपॉर्टेंट, दे नेवर रिक्वायर्ड हॉस्पिटलाइजेशन। They never required what? Hospitalization. They never have flight of ideas. They never have flight of ideas. And they never have psychotic symptoms. They never have psychotic symptoms. Okay, fine enough. So symptoms are similar to mania. However, they are not severe enough so that we can mark impairment. So they never require hospitalization. They never have flight of ideas, and they never have psychotic symptoms. Okay, done. So how can you treat the patient of acute mania or hypomania? You can have antipsychotics, you can have lithium, and you can treat by valproate. Okay. Okay, let's talk in details. First one, the first step is you need to stop antidepressants. You need to stop antidepressants. Okay, drug of choice for acute mania and hypomania is drug of choice will be antipsychotics. Okay, and you can use lithium, but it will show onset very slowly. लिथियम का ऑनसेट बहुत ही लेट आता है, सो लिथियम विल हैव द इफेक्ट बट इन अ लेटर हाफ, तो यू हैव टू स्टार्ट एंटीसाइकोटिक बिकॉज इट विल शो ऑनसेट very in a soon time, in a very less time. Lithium will show effect, yes, but in a later half. Okay, so it's slow, but lithium have one side effect, it is a teratogenic drug. It is a teratogenic drug, and what is its teratogenicity? Abstinence anomaly. Abstinence anomaly, which is a CVS defect. Okay. Okay. Let's come to valproate. We should avoid valproate in female. We should avoid valproate in females because, and what kind of females? Reproductive age female. We have to avoid valproate in the females, those who are of reproductive age, because valproate have a side effect that it can cause what? PCOS. What is PCOS? It is polycystic ovarian syndrome. Okay. Along similarly, valproate is also a teratogenic drug, so we should avoid in pregnancy because what is its teratogenicity? It is neural tube defect. It is neural tube defect. Done with this thing? Fine enough. Fine enough. Let's come to bipolar depression. What is bipolar depression? Patient may feel happy and suddenly patient feels sad. That is bipolar depression. Okay. Patient may switch to other side because of antidepressants. They never. So if a person is having bipolar depression, we should never ever give antidepressants alone. Always remember, we should never give antidepressants alone to a patient suffering from bipolar disorders. So, what should we give along with the antidepressants? Mood stabilizers. Absolutely. We should give what? Mood stabilizers. We should give what? Mood stabilizers. Okay, fine enough. What kind of drugs do we know? Fluoxetine, lithium, lamotrigine. And we very well know lamotrigine is a mood stabilizer. And it is also used for depressive state. It is also used for depressive state. Done? Fine enough. Okay. How can you how can we do prophylaxis or maintenance of this disease? Whenever a patient is having two or more episodes, when a person is having two or more episodes, we should provide them or prescribe them lithium and valproate. We can provide them lithium and valproate. Okay, fine enough. So